Hi all. Thank you for giving me a chance to present our study in this call. I'm Chungsoo Kim from South Korea. I'm PhD candidate in Ajou University. Today, I would like to present our recent study, which investigated the safety outcomes of antidepressant in adolescent ADHD patients with comorbid depression. This study was published in Psychological Medicine last month. ADHD is one of the most common neurobehavioral disorders of childhood, and this disease is affecting academic achievement and social interactions. For the treatment of ADHD, most patients are prescribed stimulating agents such as dexamphetamine or methylphenidate. Because amphetamine class is not approved in South Korea, therefore methylphenidate is the only stimulant for ADHD in Korea. The American Academy of Pediatrics strongly recommended that when managing patients with ADHD, it is important to diagnose and manage their comorbidities, not only ADHD. So the depressive disorder is the most common comorbidity in ADHD. So to treat this depression in child or adolescents, selective serotonin reuptake inhibitors are usually prescribed. Escitalopram and fluoxetine are the most commonly prescribed SSRIs in South Korea. When I discussed with psychiatrists, I was quite surprised that while it is routine for clinicians to prescribe antidepressant to patients with ADHD, but there is less evidence than I thought about the safety of the concomitant use of ADHD medications and antidepressants. Because antidepressants can cause changes in the mental state, which can lead to severe adverse events such as suicidal ideation. Therefore, the safety evaluation is definitely needed. The AAP guideline also noticed that combination use should be evaluated for its effectiveness and adverse effects. So we aim to generate high quality evidence by conducting a safety assessment of combination therapy of methylphenidate and SSRIs in adolescent ADHD patients. We designed a retrospective code study according to the population level estimation approach. For the data, we converted national claim data of the whole ADHD population in South Korea to the CDM version 5. Our primary objective was to compare safety outcomes between the methylphenidate plus SSRI group and the methylphenidate alone groups. So we then performed comparison between combination of methylphenidate and each ingredient of SSRI. For the outcome, 15 outcomes were evaluated. The outcome included neuropsychiatric events like suicidal behavior, cardiovascular events like arrhythmia, and other events including GI events or traumatic injury. The detailed definitions of study populations are in our study protocol. Actually, we want to fully adopt the Odyssey methods in this study. Therefore, we applied clinical equipoise evaluation and confounding control using the Rogers scale properties score. We also conducted subgroup and sensitivity analysis by follow-up methods and various definitions to increase the validity of our study result. The full protocol was registered on the EUPAS registry before the study. For the result, before we evaluate the safety outcomes, we investigate the empirical equipoise of the study groups. We assessed that all study groups were comparable according to empirical equipoise over 70%. After that, we evaluate the safety outcomes. After probability score matching, 2,650 patient pair were selected for the comparison between the SSRI combination group and the MPH alone group. And the fluoxetine versus escitalopram comparison, each group selected 1,820 patients each. The standardized mean difference for all variables were less than 0.1. Group in each comparison were well balanced. These are our main results for the 15 safety outcomes. For adverse events, there were no significant differences between MPH alone group and this SSRI combination group. In addition, the differences in all adverse events between fluoxetine group and escitalopram group were not significant except the tic disorder. It is not possible to show all the results in this presentation. The results were consistent in the sensitivity analysis. We found that the significant differences in tic disorders in the fluoxetine and escitalopram comparison was also consistent across all analytic settings. And we realized that this was mostly presented in the male group. We suspected that the difference in the tic disorder was due to the differential dopamine action on the serotonin 2 receptor by fluoxetine and escitalopram, but this difference is still required for the studies. I think the strength of this study is that it is an extensive large-scale analysis of the safety of combination therapy of methylphenidate and concomitant SSRIs in adolescent ADHD patients. Also, through this study, we could suggest that the combination of SSRI is generally safe. Limitation of this study includes that the fact that this was a code-based retrospective study with no clinical assessment or evaluation of the ADHD severity. Personally, I wish that I could do negative or positive control calibration of a hazard ratio according to the Odyssey recommendation, but there was not enough negative control cases in the adolescent population, so it was not possible. In conclusion, we can assure you that the combination of SSRIs is safe and effective option for controlling mood symptoms in adolescent ADHD with depression. However, further studies are still needed with data of the different age group or with data from the other countries. And yeah, this is my presentation, and thank you for your attention. If you have any question, please feel free to contact me or Dr. Dongil. Thank you.